Hi, I'm Dr. Tiffany Lamonde from Apex Wellness Providers, and this is
Dr. Stephanie Hope.
And this is part 3 of a series about pelvic health and wellness. And today we're going to cover the anatomy and physiology of the pelvic region.
Yes.
Okay. So can you give me, as best you can, a layperson's anatomy, physiology, pathophysiology of the pelvic region, pelvic floor?
Yes.
Okay.
Okay.
Let's do it.
So this is your pelvis. It's not your pelvis, but this is a pelvis.
This is a very tiny pelvis.
This is a very tiny pelvis. Yes.
Not my pelvis.
No. But
this pelvis has not had babies.
No. But a female pelvis.
So how can you tell the difference between a male and female pelvis?
Well, pelvis is a bit wider set. We've got a bigger opening down here for babies.
That flares more.
Flares more.
Mm-hmm.
Obviously, there's more holes in the pelvic floor.
An extra hole.
Yeah.
But also, you know, when you're anatomically touching a female and a male, the male pelvis is so much higher than you think.
Mm-hmm.
Like people are poking around, I'm like, that's not the top. It's way
right,
up.
because it's like here versus here.
Exactly.
Mm-hmm.
And so a female pelvis, I feel, is more obvious to palpate.
Mm-hmm.
And also men, if they have any extra body mass, it tends to be more in the abdomen, although genetically women are shifting in that direction over the last decades. But whereas women, we tend to have that curve in, and it's, you know, it's like there's the top of our pelvis.
Like your waist. Yeah.
Exactly.
Yes.
Okay.
So there are two halves of the pelvis here, joined by the sacrum in the back, end of your spine here, so I'll turn it around there. There's the sacrum and then the coccyx, or the tailbone there.
And this demonstrates L5 and L4, this particular model.
Then if you look inside, this is your pelvic floor. So not all of this is pelvic floor. It's got some of, most of it is. It's also got a little bit of the deep hip rotators that are in there.
And some of those are kind of technically considered part of the pelvic floor, like the obturator internus in particular.
Yeah, they're besties to the pelvic floor
Yes.
for sure.
They kind of yank it up.
It helps work with the pelvic floor to help stabilize.
But you don't like my explanation? Yank it up?
Yes.
You have better ways of explaining this, I feel sure.
I use all kinds of funny words, but I don't think I've used the word yank. So this pelvic floor sits inside the pelvis like a muscular trampoline or like a little bowl.
Mm-hmm.
It helps to stabilize the pelvis on both sides. It works with our diaphragm as we breathe, which imagine the diaphragm's up here.
Yeah, and just to kind of clarify, the diaphragm is the muscle sort of up under your ribs that when you take a breath in, it comes down.
Yeah. Pulls air into
And
the
when
lungs.
you exhale, it naturally recoils up.
Yes. Okay. So the pelvic floor is skeletal muscle. It's the same kind of muscle that you have everywhere else in your body. It contracts and relaxes just like all those other muscles do. There's a volitional and involuntary portion there that kind of tightens up reflexively when there's a big increase in pressure down into the pelvic area.
Okay, so kind of give an example of what you mean by that, and big increase in pressure.
When you cough.
Okay, sneezing, coughing,
Sneeze. When you
picking
yell.
up something heavy, jumping.
Yes.
Yeah.
Even when you go from a sit to stand. So
especially if you're deconditioned and that task is more challenging for you.
we're kind of holding our breath and on the way up.
And that's called when you hold your breath.
Valsalva.
Valsalva
Yes.
response.
Yes. So research actually tells us, for a while we were telling, this is an aside, but we were telling prolapse patients, like old school, we were saying don't do sit-ups because that's a lot of pressure down
Because
on your
that's
pelvic
functional.
area. Right. So
Because like how are you gonna get up?
Right. So don't do sit-ups because don't go to the gym and do sit-ups. But when we
what we're saying is that's old
that's
advice.
old school. That's old advice. Yeah, I don't tell my patients that.
It's also not realistic.
It's not realistic. But we were telling them that because our theory was that there was a lot of pressure put down onto the pelvic floor with sit-ups, like repetitive sit-ups over and over again, or crunches. But we know now that there's more pressure that's actually built in the pelvic floor when you do a sit to stand than there is with sit-ups.
Which of course you also must do.
So you must do that.
Yeah.
So
I mean, how are you going to get out of a bathtub, out of bed, off the floor,
off the toilet.
Yeah.
Yeah.
Out of a chair. You gotta
Right.
So what you really need to do is be able to control and balance the system.
Yes.
As opposed to just avoid activities.
Yes. So there are some patients where I say, don't just go to the gym and do a lot of sit-ups, but there's a caveat with that. It's not because I feel like they're in danger of worsening their prolapse. Anyways, okay. So the muscle is lined with fascia, connective
I say
tissue.
fascia.
Fascia, I say fascia too. Connected
Fascia.
fascia.
We're gonna go with fascia.
Fascia.
Here we call it fascia.
Yeah, fascioblastic. So it's lined with connective tissue called fascia, like a little spider web that goes over the muscles.
Mhm.
That's just as important as the muscles themselves.
Fascia is, I believe, is one of those tissues that is under-discussed, under-educated, and under-addressed.
Agreed.
And it is everywhere.
Yes.
And when it is not doing its job, it creates problems.
Yes. So sometimes we'll address fascial restrictions up here.
So like the low back area.
Yep.
Mhm.
So that we can get changes down here because of how all the lines run and how it all works together.
The longest fascial plane in the human body goes from the forehead all the way down the back of you to your toes. Fascia is the longest tissues in the human body.
This is another aside. You can cut all this stuff out. But I had a patient the other day. I was working on her neck, and she was telling me how she was feeling it in her sacrum.
Absolutely.
Yeah.
It does take either a very self-aware patient, like good body awareness, or education for people to start to recognize, like, hey, I can touch you and work on you in this area, and you feel these symptoms somewhere else, which could be referred pain,
Yes.
could be a fascial restriction, it could be a neurological symptom, and so on and so forth, because all of the things in the body are connected.
They are all connected. So there's also a lot of blood vessels down here and nerves that run through here. And then, so if you've ever heard of like pudendal nerve neuralgia, pudendal neuralgia, that's because we've got a lot of little nerves that run through here that can cause all kinds of not nice symptoms.
The most common patient population I've seen that in is road bikers. Is
Yes.
a seat, and it's in particularly in males.
Yes.
Yeah.
So if you think, well, this is a female pelvis, but if you think about being on a bike for hours at a time, there's a lot of pressure to that area. So they have all kinds of new bike seats actually that have like a cutout.
And they have female specific and male specific seats, which my seat currently is a male seat, and I hate it. I don't road bike, I mountain bike, but it's not comfortable.
Yeah.
Because it's not made for my anatomy.
Yeah, it's a huge problem for bikers actually, for men especially.
And they're super forward flexed as road bikers.
Yes.
So there's just even more pressure.
Yes.
Yeah.
For a long period of time. So fascia, nerve, blood, muscle, and then bone. So we've got the bony kind of support on all sides here. I get patients to get these sometimes when I have a partner that's working with the patient to do some manual release, because a lot of partners are very visual, men are very visual, so it helps to know, like, if we're doing release, we're going in and we're working on these muscles here when they're helping their partner.
Okay.
So here we go. So this is, we'll look at it like this.
So to orient,
So that's the sacrum, and the end of the spine here, sacrum.
this would be your back.
That's your
This
back.
would be your pubic bone.
Pubic bone in the front, pelvis there. And then for the female, you've got these two kind of hiatus or holes kind of in the pelvic floor that surround the organs. So you've got your musculature that's in here, the ones that are technically the pelvic floor, your pubococcygeus, puborectalis, your iliococcygeus, and ischio-coccygeus.
These are big words. We don't necessarily expect you to know all these words, but to just understand that there are pieces that are directly in the pelvic floor and then indirectly.
Yes, and those come together as a group to be called the levator ani,
Which means?
to elevate the anus.
Anus.
Yes.
Yeah.
But when I'm talking to my patients about it, we just say the pelvic floor. Then you've got the obturator internus on both sides. That's an external rotator
Of the hip.
of the hip. Yes. And then you've got the piriformis back in the back, and that's also a hip rotator.
Which a lot of patients will either get a diagnosis or perceive that they have piriformis syndrome, which may or may not actually be true.
Yes.
True piriformis syndrome is actually relatively rare.
Yes.
It can happen, but it is not nearly as common as people perceive.
Yes. So I've got patients who come in and tell me they have piriformis syndrome, and it's really actually their pelvic floor, or it's further up, right? It's from their back.
Yeah, all kinds of things.
So this is the deeper layer of the pelvic floor. When people are thinking about the pelvic floor, when they're doing a Kegel exercise or Kegel exercise, this is really what they're targeting. There's a superficial layer, so if we're gonna flip it there, this is as if you're kind of having a pelvic exam. So this is what you would see kind of from the bottom up. So this is sacrum back here, pubic bone in the front. These two bits right here are your ischial tuberosities. So these are your sit bones. We both did this.
Which, because we demonstrate to people, like, when you sit, you're supposed to sit on them, not sit on, like,
on your coccyx.
your butt flesh.
Yeah. On your tailbone.
Yes.
Yeah.
Sit up.
Sit upright. So this has a little superficial layer of muscles that is also part of the pelvic floor. It's just much closer to the surface of the skin. So these muscles kind of connect side to side here from the ischial tuberosities and then up towards the pubic bone. And then you've got your external sphincter, anal sphincter, that goes around the anal opening here.
And vaginal.
Yes. It's a different
Where's
muscle.
the urethra?
It goes right there.
Oh, it's all considered, this is all part of it?
Yeah.
Yeah.
So
Okay.
this is the urovaginal, urogenital hiatus.
I think you said that too quietly. I don't think they heard you.
The urogenital hiatus.
So it has the urethra,
The urethra
and the vaginal canal.
and the vaginal canal. Yes.
So now she's going to do a quick touch on the subtle differences between the male and female anatomy.
So men have pelvic floors too.
City?
Surprise, surprise. That actually surprises a lot
They
of
just
men
don't
when I
squeeze
tell them.
babies out of them.
No. But their pelvic floor is very important. So the musculature, we'll turn it like we did the other way. The musculature is actually not that different. We just have a difference in openings here. So there's one opening as opposed to two in what you saw in the female anatomy. So it's the same musculature by the same names. And we call it the levator ani, pelvic floor. And then you've got your deep hip rotators and then your piriformis right back in the back.
So ultimately, the deeper anatomy is essentially the same aside
Yes.
from the hiatus.
Yes. The superficial is different because you've still got the transverse perineal that goes across from the ischial tuberosities, but then you have some muscle that kind of goes on the underside of the penis that obviously women don't have. So this means that I give slightly different cues to men versus to women for contracting that pelvic floor. It feels a little different to them, and we have to use different descriptors to get them to.
I'm super curious if the descriptors that you give are similar to my descriptors. We can cut it out if we need to. But what do you say that that's supposed to feel like?
So for women, I use a bunch of different ones because
And they usually need 3 or 4 to get it.
yes,
Right.
and we'll usually do it when I'm doing the exam. So I'll say,
Which
I want
is
you.
a huge advantage.
Yes, because sometimes they'll go, oh yes, I know how to do a pelvic floor contraction.
And when they do it, they're pushing down.
yes, they're either bearing down or they're just squeezing their butt together.
cheeks. Correct.
And absolutely nothing's happening with the pelvic floor
I'm super curious if during my exam, if I'm actually capable.
of contracting. The
I
pelvic
have my suspicions, well, because I've spent some time checking that out.
floor.
I feel like there's certain regions of mine that are weak.
Mm.
So we'll have to see.
So it's also, I tell people, contract like you're stopping your gas and your urine at the same time.
I use the gas one for men a lot.
Yes.
I feel like that one's more effective for them. Is that fair?
Yes.
Okay.
But you can still get a contraction that's just around the external anal sphincter, and they're not getting a deeper kind of contracture.
So there's better ways to say it.
Yes.
Okay.
And so I'll say, like, you're stopping your urine flow.
But don't actually do that.
Yes, don't make that a habit. Don't do that as an exercise. It's not good for you.
What does it cause? Or what can it cause?
Retention, urinary frequency,
It can contribute to
pain,
infections.
It's just not normal. Just don't do that.
The only time that I've ever really tried to do that, this is a side note, I was backpacking, and you know when you're backpacking, you're like dropping trowel and peeing all over the
There's
place,
someone like coming around.
and someone's coming around the corner, I'm like, ah! I'm
Yeah.
trying to pull my pants up. It was really
hard.
because not only was I like in the midst of urinating, but I also had like a 30-pound pack on me, and
you're
I'm
in a deep
squatting, which I should have taken the pack off. But I was like, I just gotta go, and I just want to keep going, and I really couldn't stop.
Yeah. I mean, with a full
and I'm like,
bladder,
hey!
it's difficult. Yeah. I mean, if they're backpackers, I'm sure they're used to seeing all that kind of
Yes.
stuff too.
Thank goodness it was number 1, but the anatomy is
That's
the
true.
same.
That's true. Your butt's still waving in the wind. Yeah, true.
That's a true story.
So sometimes I'll tell people you can try, if you really don't get it in the exam or with the exercise I give you, you can try doing it one time on the toilet.
Okay.
Not when your bladder's super full,
Okay.
because it's really hard to contract around that amount of pressure.
Because you're here because you're already having some difficulty.
Yes. So you can try it 1 or 2 times and that's it. We don't make it a habit of stopping your urine midstream.
Mm-hmm.
Yeah.
That was old school.
Yes.
Back in the day, like 20
Yes.
years ago when I started
Yes.
practicing.
And there's still healthcare professionals that give that advice out, and then we're having to retrain that. So I had patients that originally just had stress incontinence. That was their problem.
They developed urgent incontinence.
And yes, and now they have retention and pain and frequency and all kinds of problems. So don't do that.
Don't do that.
Yeah. So this is a view like we've kind of chopped you in half this way, and we're looking from the side on. So what you can see here, you've got your bladder, nice empty bladder, uterus, ovaries, and then rectum down here.
So to orient, this is the buttocks.
Yep.
Sacrum.
And this is this white bit right here, that's the pubic bone in the front.
Right. So just so that you understand that the bladder is what we call anterior or in front of the vaginal canal, which becomes relevant for a lot of dysfunction. The uterus is above the vaginal canal, and then the rectum is posterior or in back of.
And then the ovaries kind of sit up here. It doesn't show exactly how they're all connected because of the way that the view is.
Right.
But the ovaries sit up here, and they're kind of suspended by suspensory ligaments above that are also not shown in this picture.
That would be more of an AP view.
Yes.
This way.
So I like to show this picture to patients because I want you to know how the organs are actually kind of oriented in the pelvis, and you can see what the relationship is to the pelvic floor. And then a more global view, you can see the relationship of the organs and the pelvic floor to the rest of the core.
Right.
Yes.
Which is a concept that I think people don't connect. Like people have gotten better about connecting, maybe not why, like my core is related to my back pain, but not necessarily how my core and what all the core entails is connected to my pelvic dysfunction.
Yes, agreed. So I'm gonna draw really quickly what I do for patients. Let's see. So I draw with my little handy marker here because I want you to see, and I'll actually get a little closer just for this one bit. So as you can see here, these are the 4 different sides of the core. Okay, so we've got our ribs, our diaphragm that sits there, that's our breathing muscle. You've got the abdominal wall, connects right down into like the pubic bone down here. This is the pelvic floor, and then the muscles that line the spine and kind of the glutes back in there. So all 4 of the sides work together to manage pressure. That's the job of the core.
Pressure management.
Pressure management and stabilization. So one of the most important things I want patients to understand is the way that the diaphragm and the pelvic floor work together.
Right.
So the diaphragm is working all day long because we got to breathe, right? So it's going up and down, down when we inhale, up when we exhale. That pressure, when we take a big deep inhale in, comes down, and that's dispersed within kind of the abdominal and like the pelvic area. So that pressure goes out towards your tummy. So that's why if you take a big deep breath, belly rises. It goes back towards our back and then down towards our pelvic floor. And if that pelvic floor is nice and relaxed, that pressure goes all the way down there, and we actually get an opening of the pelvic floor a little bit of a dilation.
I think that people do not realize that it is supposed to move.
It is supposed to move, and if it's not moving,
Problems.
there are problems there. And if it's not moving, we can't get a really good contraction. So yeah, lots of problems with that. So that's one of the main things that I teach patients is like, we got to get that moving again. And then also I just want you to be able to tap into that area and know what that feels like.
Yeah.
So you should know what it feels like when it's tense and tight, and you should know what it feels like when it's nice and relaxed. Yeah. So I'll tell patients, breathe into your, my patients will watch this and be like, oh yeah. I tell patients to breathe into your butt or breathe into your pelvis. Your air doesn't go down into your pelvis. The pressure is dispersed. It goes down there. But once they understand that, and I say, okay, let's breathe into our butt, they understand that. But then other PTs hear me do that, and they're like, Stephanie, it's not possible.
Well, and it's so funny because the things that we say in order to help a patient to understand, right now we're recording what we're saying, and we have no control over who watches this video.
Right.
And we're giving as much education as we possibly can to at least initiate understanding. But the reality is what people understand and what they take away from it, we have no control over that.
Completely.
So once in a while, patients will come back and they'll say, well, you told me this, and we're like, that's not exactly what I
Not
said.
true. Yes. So
that's what you heard,
right?
Or you understood from what we discussed. So let's go over that again.
Yep. So we do a lot of education and re-education and re-education and re-education,
which is
normal.
Totally normal. Yes.
Because we throw a lot of stuff at you, so it makes sense.
We want, and no one expects you to understand 100% of everything that you learn from one session.
Agreed.
That's not even possible.
Yes.
And everyone, this is true whether you're talking about something as specific as the anatomy of the pelvic floor or starting an exercise routine, everyone starts in the same place. We're all beginners. Stephanie did not know what this was when she was 12.
No.
Or even 20 perhaps.
No.
Well, maybe by then you did.
Well,
at least some of it.
I knew some of that,
But the reality is
stuff.
that we don't expect you to have the same level of knowledge instantly that it took us 22 years of practice and 10 years of education to obtain. So
for sure,
that's okay.
And when I'm doing the initial education with patients, some patients I go into really deep detail because they really want to know all of it,
and they have the background or desire to do that.
And then some don't want to know much at all about it. So I just say, okay, we got this, this, and this. This is how they work. And then
breathe in your butt.
Yeah, breathe in your butt, and then we move on from there.
That is the skill of a good educator, knowing your audience and how to accommodate their specific
when you can
place.
See when their eyes glaze over. We're like, oh, too much.
Too much.
Yeah.
Let's
reel
backpedal
it back. Yeah, exactly.
I loved the piece about the misconceptions of what exercise should and should not be done. And as educators, we all kind of have a responsibility, and I'm using a platform right now as a tool of education, but there's also so many great educators, and then there's a lot of misinformation. And
especially today's world of like YouTube and social media and all of that, there's a lot of things that are circulated around that aren't necessarily kind of like rooted in research, or like very old school way of thought.
Well, and that's another good point. As research evolves, so does what we learn, teach, and that's a very important thing as a scientist, as an educator, as someone in the healthcare or any profession. If you have 20 years of the same year of experience, you're probably not current. And so I can easily attest to the fact that the provider I was 22 years ago is extremely different than the provider I am today. And that's because of what information is available.
Definitely.
And so it's my job to obtain, understand, and evolve my practice around what is most current. And 20 years from now, this may actually not be best practice.
Right.
And so it will be our job to continuously evolve. And so I tell my patients, I read lots and lots and lots and lots of research so that you don't have to.
I mean, I don't tell my patients the same thing now what I told them even a year ago.
Right, because your knowledge base has expanded. And then additionally, as providers, the more years of practice that you have, the more you can pull from your experience. So if some obscure disorder comes into your office the first time, the amount of brain energy that requires is very high. Now, if you've seen that same problem 1,500 times, your pattern recognition is so much quicker. Now, with that, it can develop a bias. So it's our job to also say, okay, I think I know what this is, but I still need to do a thorough exam and a thorough history. Because and I think I can speak for both of us, am often very surprised at what I actually find. You're like, that was not what I was expecting. This is why we do an exam. And I tell my patients that. I had a few diagnoses in my mind of what I thought I was going to rule in or rule out, and I was completely wrong. And this is why the exam is so important.
So I tell my patients the same thing. Based on their symptoms, we kind of, in pelvic health, we kind of lump patients into different categories. So it'd be like, there's the strength camp, like they just need more strength.
Which is not as common as people think.
No.
Everyone thinks it's because they're weak.
Yep.
And that is not always true.
So there's the strength, there's the ones that need behavioral retraining, so we need to work on their behaviors. It's not really a musculoskeletal thing so much as their behaviors. And then you've got the ones that are overactive, hypertonic, tight, restricted.
And I think that we see a lot of those patients, especially through our athletes. A lot of them come in thinking they're weak. They've done a million Kegel exercises, and the reality is they're so hypertonic, they cannot relax these tissues. And that's the pathology they're really dealing with.
So I just had a male pelvic patient that I had last week. He was coming to see me for urinary retention, difficulty initiating stream, which initially he thought was a prostate problem, and worsening constipation. So he said, well, I had gone to this other pelvic floor therapist, and she was getting me to do a lot of pelvic floor contractions, and that's mostly what we did during the sessions with biofeedback. And I said, okay, well, how did that work for you? And he said, well, actually, my constipation's actually gotten worse since I've been doing those exercises. So I explained to him about the importance of relaxing musculature, and when you go to use the bathroom, peeing and pooping, it's important to relax so that we can
so
we can pass something out of our body. And so we talked about that. I coupled it with the findings that we had during the exam. It actually turns out that he did not need to do pelvic floor contractions.
He was hypertonic.
That he was, yes, it was overactive, and we needed to do some hip opening stretches. He had been given some information that was not appropriate for him. So it was making him actually more symptomatic than it was helping him.
So that would lead me to believe that assumptions were made, maybe in his first experience, without actual clinical examination to confirm or deny that.
And that does happen with technology, with biofeedback that a lot of pelvic therapists are using now, which can be a great tool. It can be so amazing. But if you're not coupling that with what you're actually finding with your hands, then it can give you some false information.
Okay, so I think in summary, what we're going to move on to in our next video is I am actually going to go through an entire pelvic health exam. My first one, I have never had one. Now, I've had a pelvic exam, obviously.
Yes.
I've had a hysterectomy, so I've had plenty of things in this area.
But not by a pelvic PT.
But not by a pelvic PT. And so we're going to go through a full exam, a full history, a full exam, and education. If appropriate, I'm going to be given a home program or whatever needs to be done. And then the final and fifth follow-up video will be how has that worked out. She'll be, I'll come back in for another appointment and we'll discuss and or modify whatever my homework assignment has been.
Yes.
No pressure that she can help me. Because I don't have terrible problems, although at one point I did, so that will come out in the history. But I do have a little, and so we've talked about this. That might not need to be my normal. I'd rather it not be my normal, And that is one of those things that's probably not going to get better with time without some help. So rather than me get progressively more frustrated, let's just take care of it. And in the spirit of education, I am giving myself a very uncomfortable circumstance on a very public format for your benefit. So those of you who are watching this, you better appreciate this and the whole hysterectomy series. I'm going to be doing a colonoscopy series. And if I am going to put myself out there that much on a public format, there better be, first of all, be kind, be nice.
Yeah.
And two, I actually really hope it's helpful for people.
Yes.
If someone wanted to come and visit you,
You can give us a call to Apex Wellness Providers, and you can make an appointment with me for an initial visit, or Dr. Harrison. You can schedule online, so you can go ahead and go onto our website, apexwellnessproviders.com, and make yourself an appointment there. You can contact us through the contact form, and we'll have our office staff reach out to you and find a time that's best for you. Or if you can't come see me and you really want help and you think that the stuff that you're hearing from me makes sense and that you want an assessment from me, then we can do a telehealth visit.
Yeah, if you live too far away,
If you live too far.
you don't live near Cumming, Georgia, there are options to do telehealth appointments.
Yes, and those are really successful actually for a lot of patients. I've even had chronic pain, pelvic pain patients that have done really well with those.
Perfect. Yeah. All right.